Hi, and welcome to today's presentation. My name is Mike McNamara. I work in the cardiovascular health program and manage both the cardiac and the stroke recognition awards. Today's presentation is going to focus on stroke care, and hopefully you'll be able to find some pearls in here that you can use to improve the stroke care in your facility. Today's presenter is Todd Moore. Todd's a physician assistant working at St. James Healthcare in Butte. He's worked in the emergency department for over 20 years, and for the last year provides full-time healthcare education as the quality program coordinator. He became an EMT and worked on an ambulance at age 16. He joined the Air Force at age 17 as a fire protection specialist. Todd completed the Air Force Physician Assistant program over 25 years ago, and he's the medical director for several EMS services in southwestern Montana and believes that it is his way of giving back to his roots. So Todd, go ahead and take it away.
Thank you, Mike, and thank you again for the opportunity to be here today to be able to give back to you some of the information that I've learned over time. I will be the first to admit that I am not the smartest guy in the room, and I have to give credit to those that have actually studied and developed this information. I just like to be able to package it in a way that is understandable for me and be able to bring that to you, hopefully in a easy to understand format. One thing that I like to do is give you tips or time savers. This is where we live. We are certainly blessed to be able to call Big Sky Country our home. And this might be what a lot of people in the country think of when they think about Montana medicine. However, this is who we are. We have some of the best practitioners, nurses, EMTs, best qualified in the country, and some of the best services available in the country. We all need to understand that we're held to the same standard of care when it comes to taking care of our patients. If we were taking care of a patient in Los Angeles or in New York or in Butte, Montana, they deserve, and the expectation is the same standard of care. So the basis of my talk today is understanding the rules and figuring out how we can provide the best care possible for our patients in the most timely manner. So this is the suspected stroke algorithm from the American Heart or the American Stroke Association, and these are from the 2020 guidelines. And we'll just touch base on a few key points in this. We want to identify our signs and symptoms of a possible stroke as early as possible and get that patient to definitive care, which is going to be, in this case, giving them TPA as soon as possible to try and open up that vessel in the brain that's occluded. Our EMS actions, we're going to start with our ABCs, give them oxygen if they're hypoxic. We need to start the stroke protocol, and we need to notify the emergency department in our critical access hospital or wherever we're taking the patient that we're worried about a stroke. We want to do some sort of pre-hospital screening, and we need to determine when they were last known normal. And then what a lot of big centers are doing is taking them to an appropriate stroke center. And I'm going to touch base on that a little bit later on what our options are here in Montana. Once they hit the door of the emergency department, we want to activate our stroke team, and we need to get them in the scanner. This is going to be our key trigger, letting us know if the patient is having a hemorrhagic stroke or if they're having an ischemic stroke. and then we're going to get our IVs, EKG, chest X-ray, but our main focus is getting them into the CT scanner as soon as possible. So based on our imaging, if they've got a hemorrhage or an intracranial bleed, then we're going to follow that protocol and we're going to get them to the appropriate neurologic services. If they do not have a hemorrhage, then we need to consider if they're a candidate for TPA. If they are a candidate and we complete the checklist, we're going to give them the TPA. And we need to also consider if this is an LVO or a large vessel occlusion, where we can go in and actually retrieve that clot. And we're going to talk more about that as we go through this program as well. So if they are a candidate, then we're going to get them to a center that's able to do that. If they're not a candidate for that, then we're just going to admit them to a stroke unit or a neurologic ICU and continue to observe them. So some times that we need to be aware of. From the time the patient hits the door of the emergency department, the provider needs to be face-to-face with that patient in less than 10 minutes. From the time the patient hits the door to the emergency department, they need to be in the CT scanner. Now, some places are still doing 25 minutes. The 2018 guidelines had looked at 20 minutes, and that's what a lot of places are striving to do now. That CT needs to be read by the radiologist within 45 minutes. And if there's no intracranial hemorrhage and the patient doesn't have any contraindications to TPA, we need to have that on board, injecting that in 60 minutes. So let's take a look at where we are or what our numbers look like for the last year. I'm not going to drown you in data. I'm not going to go through every little piece of information that's on the reports, and the state's done a fabulous job at gathering the data so that we can look at this and find areas that we can improve on for our patient care. And this looked at the 12 critical access, stroke recognized critical access hospitals in Montana. So 63% of the 142 patients who had some sort of stroke diagnosed in 2020, 63% of those were ischemic, and only 12% were hemorrhagic or an intracranial bleed. The majority, 55%, arrived via private vehicle, and 34% were transferred to a higher level of care. The last known well time had been documented almost 70% of the time, and the last known well to the emergency department arrival, how long before they showed up at our doorstep, was an average of 99, almost 100 minutes. This shows that the majority here did come in 100 or 100 under 120 minutes, under 2 hours. Here we can see that our door to CT scan, the average time is 31 minutes, and that's an area that we can definitely improve on. And then we want to have our door to CT scan read in less than 45, and another area that we can improve on. And our door to needle should be less than 60 minutes. And here we can shave some time off of that as well. This looks at our percentage of stroke patients that received the NIH stroke scale, and it's almost 80%. Door to CT, and the state had actually looked in the 25-minute window, and that's fine, but we're only at 50% of the time there. And then CT read less than 45 minutes, less than 50% of the time. And then looking at our critical access hospital stroke recognized. Our TPA contraindications were documented almost 80% of the time. If they were a candidate for TPA, meaning they met the criteria and they had no contraindications, we only gave TPA 20% of the time. So it's definitely an area that we can improve on. TPA given among all ischemic stroke patients, only 15% of the time. And our door to needle less than 60 minutes was only 24% of the time. Those that did receive TPA, these are the time frames in which that was done. I also like to tie in the EMS annual report, the data that was acquired for the EMS, our EMS brothers and sisters, because I think it has a direct impact on what we provide as well. So these are our stroke patients. They had looked at about 1,500 911 responses for suspected stroke. And the on-scene time was less than 15 minutes, only about half the time. So it's an area of improvement there. They were checking glucose as well, about 80% of the time. They were notifying the emergency department in our critical access hospitals only about 23% of the time did we have heads up that this could be a stroke coming in. And then our stroke screen, they were documenting that about 70% of the time, not doing so great on documenting last known well. The symptom onset time, they're a little bit better at. And then completing a thrombolytic checklist for us, I don't know that that's an absolute requirement. It certainly does help save time for us in the emergency department. So where are we going, or what can we do to improve our patient care based on the data we're seeing? What are the low-hanging fruit, and what are the areas of opportunity that we have for us? What can we do better? Following the American Stroke Association and looking at the steps that we go through and trying to determine how we can improve our patient care. One way is the American Stroke Association is really good at getting out information to our communities. And we can certainly access this information. And Mission Lifeline for Montana just got a new grant that can help us in many variety of ways, including that public access or public information, getting the word out to the public to recognize the symptoms and call for help as soon as possible. Another thing we can do is work with our dispatchers in recognizing the symptoms or trying to tease out that information to give that to us, to let us or give us heads up if this is a stroke. Also, if I'm the EMT responding, I might let or have dispatch notify the emergency department if I can't get a hold of them directly. And some of my EMS services don't have direct radio contact to the ER. So they can talk to dispatch and give the ER heads up that this could be a stroke coming in. And what I routinely do when I get that information when I'm in the emergency department is notify CT right away. So if they've got someone that's inpatient, that's on the table, or they're going to bring someone down from the ICU in about 10 minutes to do a scheduled procedure, they know to clear the table. So I don't have to deal with that if they have that heads up. Also, having a stroke champion is huge. Someone in your facility that cares about how we can improve our patient care. That's a huge thing to help with education and identify areas of improvement. And then looking at some systems of care, making sure that we've got our phone numbers available at our fingertips for our flight services and calling them early when we suspect stroke so that they can be en route even while we're still working up our patient. Developing a stroke alert system so that everybody in the facility knows that we're dealing with a stroke and this is a medical emergency and that we're taking care of this as fast as we can. And then sending out your pages that there's a stroke alert instead of just paging the CT tech to come in for a CT, letting them know that it's a stroke alert and there's a time limit on their response. And then this is a tool that I came up with for triage at my hospital. What we use is the BFAST for triage. And if any of these are positive, the patient is brought back to one of the high acuity rooms directly as a level 2 patient. We get them in the room, start getting vital signs. Either the technician or even the provider will notify CT that we've got a stroke patient that we're working up so they can make sure the scanner is open and clear. We work on getting our stroke score, drawing our labs, even letting the pharmacy know that we are thinking about giving TPA. And then I'm going to get an EKG and chest x-ray. After CT, there's nothing more frustrating than the CT tech comes rolling down, they're ready to take the patient and x-rays in there, or they're in the middle of an EKG. Those come after CT, not before. And also getting our iPad out and fired up, ready to go for a neurology consult. And I know that's a lot to juggle, but with practice and communication and a team-wise approach, it's certainly something that we can accomplish. We do it for trauma, we do it for MI, and we do it for sepsis. We want to do the best that we can to get that patient into the CT scanner within 20 to 25 minutes, or as soon as possible. We need to have a system set up where the radiologist is notified immediately of a stroke so that they know to be at their desk looking for the images. And instead of me as an ER provider waiting for the report to come across the Synapse or the PACS system, I get a phone call from that radiologist who gives me that report as fast as possible. We also want to make sure that we're doing our stroke scale. And there's a newer one out, which is in plain English. And there is a training program and a certification program. And depending on the level of your stroke certification will depend on if your nurses need to be certified or just trained in this. This is the gold standard test, the NIH stroke scale. And this needs to be done in the first 15 minutes. Again, that's a juggling act in order to get that done and get your patient to the CT scanner. But with practice, we can do that. Well, what do our EMS partners use? That NIH stroke scale, there's a lot there, and it takes a few minutes to go through that. It's a lot to remember to try and do all this questioning and testing on the patient. So what we need to know first is this even a stroke? And then the next thing we want to know, is this an LVO stroke or a large vessel occlusion? And this is newer information for a lot of us on the large vessel occlusion stroke. So we're going to look at that pretty closely. So again, number one, I need to know, is this a stroke or not? And I want to beware of the imitators. Could it be alcohol or drugs or a migraine or an intracranial hemorrhage or hypoglycemia? And listening to Dr. Talib, who has come up with the VAN stroke scale, I liked how he put it. This is stroke. This is not. So if they can't hold up both arms, it's probably not a stroke. One tool that we've used, and this is the one that I've used for the longest time, both in pre-hospital and hospital care, is the Cincinnati stroke scale. And it's pretty good. about 72% specific for a stroke if they have one of these three that are positive. A newer one that a lot of places around the state have adopted and are using is the BFAST. The first thing that we ask the patient is, are you dizzy? Is your balance off? Are you lightheaded? Are you able to walk okay? Or do you have any visual changes? Then we have them smile, hold their arms up, and check their speech. And what I use, and everybody has their different ones, is you can't teach an old dog new tricks. Then we want to know the time when they were last known to be well. The next thing after we do our screening is determine, is this a large vessel occlusion stroke? There's two types. There's ischemic and our bleeds, hemorrhagic, but then there's two types of ischemic, our LVO or our lacunar. And our lacunar stroke involves the brainstem. The LVO involves the cortex. So if our bleed is in this area in the brainstem, that is a small vessel or lacunar, and it's only about 20% of the time. Our large vessel occlusions involve the large vessels to the brain. What they can do now is actually go in and retrieve that clot and get that out in a lot of different places. So TPA is relatively new. It's only been around less than 30 years. And a lot of people consider it the devil's juice, where if a small percentage of our patients end up with a bleed, that is a very small percentage. And if we screen them correctly, we can save a lot of tissue, a lot of morbidity, and a lot of mortality with our TPA. But our thrombectomy or clot retrieval is relatively new, over about the last 5 or 6 years. And what they've found, and this is only in selected patients, but in some patients, they're having benefit even up to 24 hours after when they were last known well. So that opens the window for a lot of our patients for potential improved outcomes. Now, that doesn't mean that I can sit back and relax because I know I've got more time. Time is still tissue. They're losing neurons every minute. And this is looking at the penumbra. And I relate this back to when I was a firefighter. I wasn't worried about where the fire was. I was worried about where the fire was going and preventing it from spreading to that area. So how do I know if this could be a large vessel occlusion stroke? Well, I can do a stroke severity score. And our gold standard, again, is the NIH stroke scale. But there are certain things that I'm going to evaluate to help me determine the severity. My gold standard is my NIH stroke. And if my score is greater than or equal to 6, that's a high probability that this is probably a large vessel occlusion. But for our EMS partners, it's hard to do that out in the field. So there's a ton of quick scales or scores that are out there and available for use. Which one do you use? Well, basically, it's going to be up to the medical director for that area. And one that I've chosen for my EMS services, and I know one that the state is considering for most regions of the state, is the VAN score. And this is from Dr. Mohammed Talib, and he's in Phoenix. He's a neurointerventionalist. He goes in and retrieves the clots. And so he has a website, it's free. He's got these apps that are free. And the thing I like about the VAN score is there's no number to it. You don't have to calculate anything. It's a yes or no. So similar to STEMI or ST segment elevation myocardial infarction, we can use our 12 lead to determine what part of the heart is infarcting or is not getting oxygen-rich blood. With the VAN score or the app, it's the same thing. What they are able to do is by determining the signs and symptoms and putting those in the app, you can pretty specifically tell what part of the brain is infarcting or is infected. So this is a tool that I've come up with for my EMS services. So what we do is our screening, we do the BFAST. Then all we do is have the patient hold their arms up for 10 seconds. If they are able to hold their arms up, they're done. That's not an LVO. The likelihood is very, very low. If they're not able to hold up one arm for 10 seconds, then we're going to check their vision. If they have no visual defect, we're done. Or excuse me, if they have a visual defect, we're done. If there's no visual defect, then we check their speech. And if there's none, we go to they're done. Or if there is, we're done. Sorry, I'm confusing you. If there is a defect, we're done. If there's no defect, then we check their neglect. The nice thing is there's a video on YouTube on how to conduct this and also on Dr. Talib's website. The main reason that they've come up with these is they need to know if they're going to take the patient to a primary stroke center or a comprehensive stroke center. Which way are they going to go? So if you're in downtown Los Angeles and you're having a stroke, do I want to go to a primary, smaller center or a center that is comprehensive, that has the ability to do a thrombectomy? So they may divert from going 5 minutes to a primary and take a few extra minutes to get to a comprehensive. So that was the premise for coming up with these scores. And this is from the American Heart Association, the algorithm for EMS to follow to help determine that. But unfortunately, in Montana, we don't have any certified comprehensive stroke centers. What we've had to do over the last few years is anybody that's having an LVO stroke in Montana needs to be transferred out to one of these other places. Now, fortunately for us, Missoula has started doing thrombectomies. And although not certified, only because of a lower volume, they are still able to perform thrombectomies. And I've even sent a few patients their way. And Billings Clinic in the near future is looking at this option as well. So there is hope on the horizon for us in Montana. So for us, the scoring can also help us determine, especially when they hit the door of the emergency department, if I know that this is probably an LVO stroke, what I look for on my plain film is just see if there's a bleed. If I think it's an LVO stroke, I'm going to do a CT angiography. So what I can do is say, do my non-con head and then do a contrast right afterwards because I want to see where my occlusion is. Another thing as a time saver is as soon as my patient is in the scanner, notify the radiologist. And if I can get that read right away and there's no hemorrhage, why not give TPA in the scanner? Why do I have to wait till I get all the way back to the emergency department to start my TPA? I'm doing my checklist, I'm getting my NIH stroke scale, and the patient has no contraindications, if I can get that read right away, why waste time getting back to the ER? Also, making sure that if we're going to set up our telestroke to talk to the neurologist, that we don't have to dust it off, that everybody's familiar with it, knows how to use it, and is comfortable with getting it ready for us to use. And then having some sort of resources available. And the Montana Stroke Project has done a phenomenal, impressive job over the last few years, putting together the Montana Stroke site. Just go to montanastroke.org. And I've even saved that as a favorite on my screen, so that if I have a stroke patient and I need to access this, it's at my fingertips. It only takes a few seconds. And they've got some great resources on here. Specifically, what I look at are my provider resources in the emergency department. It goes through some of the stroke scales for our pre-hospital brothers and sisters. It looks at these guidelines, which we can open up and follow, and also has some order sets that can help us with our administration. And we know that giving our TPA takes time. So why not have it ready ahead of time or early? Well, I know a lot of people are worried about the price. What if I pop the cork and then I don't use it? Maybe they've got a bleed on the CT, so I'm not going to give it. Well, Genentech has recognized this, and they will provide credit or replacement if you mix it and don't use it. And just call this number. So don't worry about popping the cork. Also, being familiar with your dosing and having that at your fingertips. Having your criteria, and then an emergency department stroke order set. And what I've done, I use Epic as my electronic medical record system, and I go into my order sets and I have everything pre-checked that I can ahead of time. So I don't have to think about each one of these things, just to help save time. So using some sort of screening protocol, I can identify my patients that need certain interventions, and I can improve my patient care timeline and decrease the amount of time it takes to care for them. So in summary, knowing the rules and using your tools, there are ways that we can improve our patient outcome. Practice makes perfect. Running like a well-oiled machine. When we don't do something a lot, we need to practice it more. And we're held to the same standard of care for our patients, and they expect the same standard of care. This is not us. This is us. And this is where we live. And thank you for your time and your participation today. Do we have any questions, Mike?
No, we don't, Todd. That was awesome. Great presentation. Thank you so much.
Thank you. It's my pleasure.